je me présente d'abord, c'est le docteur Marie-Marcel Deschamps. Je suis médecin interniste et la co-directrice de l'institution.
I work at GAISCO. I'm pleased to participate in this meeting. There are several speakers, and we will talk about co-infection, HIV/AIDS in the Caribbean and Latin America. And I am going to introduce, first of all, or share with you some information about the session and about the research team and the scientists and physicians who are going to make presentations and discuss this issue of HIV/TB co-infection. We are also going to have some panelists who Dr. Papp will moderate these sessions. And I would like to remind you that participants are currently muted. Their mics are muted. And they will have to introduce themselves interactively by typing in the chat on the right of your screen. They have to introduce themselves. So you may write your name, the organization you represent, the country you are from, and please take this opportunity to get to know all other participants, people who haven't been able to meet face-to-face, to exchange ideas. There will be simultaneous interpretation in English, Spanish, and French. So choose the language you want to hear the presentations and the discussions in your preferred language. To those of you who present with us in the Dominican Republic, these sessions will be in Spanish. We would like to take this opportunity to thank the healthcare and Gilead Sciences for their support to this virtual meeting, that is the scientific meeting. Thanks for your participation. We would like to tell you that there will be a chance to get a one-year membership, IAS membership, for free. The membership will be activated once you fill in the post-symposium survey, and you will have to tick a box in the survey requesting this membership, this one-year membership. And now I'm really pleased to introduce Dr. Bernard Leotard, a medical coordinator at the CHU regional, at the CHU hospital. He's the head of training, and he's a co-founder of the GESCU Center. He will share with us the key recommendations from the IAS Educational Fund workshop held in Haiti in 2018. After that, we'll give the floor to Dr. Maria Rodriguez, a physician at the National Program for the Control of TB in the Dominican Republic, who will talk about the new recommendations on TB and Mdr Tb specifically. After that, the floor will be given to Eduardo Gotuso, Emeritus Professor at the University of Peru, Peruano Cayetano Heredia University, who will talk about HIV and TB in Latin America, and specifically in Peru. Finally, we will give the floor to Dr. Papp, Director of GAISCO Centers, who will be moderating a discussion among 5 physicians who will talk about co-infection, HIV and TB. And now I would like to take some minutes to mention the problems and challenges our region has to face, specifically Haiti, my country, and the role that the GESCO team has to play. Because despite the difficult scenario in Haiti, we have been able to keep on working and working in the area of HIV and COVID in this country. This shows the energy and power of this team that has been working continuously through these difficult times. They have been able to keep on working, and they will share with you what we have been doing in Haiti. And this will be mentioned in this second panel. Despite the difficulties we face nowadays in our beloved Haiti. So on behalf of myself and on behalf of the organizers, I wish you an excellent session. Thank you very much. November 27 and 28, 2018, in Port-au-Prince, a workshop was held after the large IAS conference in Mexico was held. And together with Haiti, this was very important for Haiti. And the workshop was, the title of the workshop was Science and Communities in the Caribbean in the Response to HIV. The goals were, first of all, to review the status of HIV and TB in the region, and considering the findings of the conference, assess the feasibility of implementing new strategies to improve the retention in HIV care and promote PrEP among key populations, as well as improving the care of co-infected HIV-TB patients and the treatment of Mdr Tb. We carried out several analyses and recommendations. They were highlighted during the workshop. There was a panel discussion held on this issue. It was chaired by John William Papp, and we discussed the following issues: scaling up TB diagnosis in the region, integrating TB testing at the time of HIV testing, providing access to Mdr Tb treatment. Among the problems and issues analyzed, we may mention the following ones. First, the outcomes of the success of treatments in the pilot site in Brazil for the treatment of Mdr Tb, the efficacy of double dose for co-infected patients, treating them with Dolu, the limited coverage of the preventive treatment for TB, the persistence of TB, the duration of TB, which is related to the death, most important causes of death in the Caribbean, and the use of X-rays, chest X-rays, and the Gene Expert device. After the discussions, the panel suggested several recommendations. Prioritize interventions that allow for early diagnosis of TB and HIV, to gather the society to think about the dimension of TB, to increase home tests for contacts, to work on to get more X-ray devices set up and more Gene Expert devices, to develop the procedures for detections in prisons, and to introduce in the curriculum of the schools of medicine and nursing the recommendations to prevent the spread of TB, to improve the national programs for the treatment of TB and HIV. And all in all, this workshop was provided a wealth of information, and it made it possible to communicate and spread the learnings and the lessons learned from the IAS conference in Mexico. Thank you very much for your attention.
Buenos días. Muchas gracias por haberme invitado a participar con...
Thank you for having invited me to participate, to talk at the symposium. We're going to talk about the new recommendations for HIV and TB treatment. The content of this presentation is the following. We're going to talk about susceptible TB, recommended regimens for drug-resistant TB, and some conclusions. As we all know, TB treatment started with the discovery of streptomycin in 1943, when drug use started, and over the last century, new drugs were added, since it was proved that treatment could not succeed with just one drug. We had to combine several drugs, and since the 80s, we have been using a standardized basic protocol based on 4 drugs: isoniazid, rifampicin, parazinamide, and ethambutol. It's a full century, 80 years of development, and over the last century, we've seen 3 new molecules for TB treatment, which are bedaquiline, pretomanid, and delamamide. We'll see how we're using them as second-line drugs. For the first line, the recommendations, the current recommendations are the WHO guideline recommendations updated in 2017 that keep the standard 6-month-long treatment with isoniazid, rifampicin, parazinamide, and ethambutol, even over other alternatives suggested at the time, such as fluoroquinolones for 4 months. At the time, the recommendation was to drop the intermittent treatment recommendation, as well as a category 2 regimen using streptomycin as first-line drug. As regards HIV and TB management, these guidelines keep the use of ARVs for all TB HIV patients, regardless of the CD4 count. First, anti-TB treatment should be started, followed by ARV in the following 8 weeks. And regarding the recommendation to use the 8-month-long regimen, the standard 6-month-long treatment was recommended for HIV patients. These guidelines include several recommendations about support to patients, patient-centered care, and supervision, but I'm not going to deal with these topics right now. This year, on June the 6th, study 31 was published in the New England Journal of Medicine. It is a randomized, multi-country, open-label controlled trial with over 5,124 patients involving countries in the Americas such as Brazil, Haiti, Peru, and the US. And the goal was to show the efficacy of shorter regimens for the treatment of drug-susceptible TB. A 4-month rifampicin therapy with moxifloxacin proved to be effective. It was non-inferior. The WHO published the guideline and called upon a guideline review group to focus basically on the results of the regimen that showed non-inferiority with a 4-month treatment with rifapentin. And after reviewing the data, the group acknowledged that that might be an alternative since it's a shorter treatment well received by patients. However, this regimen has some limitations, mostly its cost. And it also requires that patients should have access to rapid molecular drug testing. The cost of a standard treatment is around $50 according to the Global Drug Facility prices. Only rifapentin and moxifloxacin for 4 months cost $320. Besides this review included in this rapid communication guideline, the WHO is reviewing the full guideline and the details are likely to be published by the end of this year. Within the framework of Mdr Tb, the latest guideline, which is the consolidated 2020 guideline, which also includes an operational handbook, is very useful to implement the various recommendations. It includes the publications, guidelines, and other papers published over the last decade. In order to decide what treatment to use for drug-resistant patients, some key aspects have to be considered, such as access to rapid susceptibility tests to ensure that there is susceptibility to at least rifampicin and fluoroquinolones, surveillance, and drug safety monitoring, as well as support to patients in terms of management of comorbidities. This is all very important. And of course, we have to bear in mind what treatment options are available in the different countries. There are 4 types of regimens or 4 general areas. Isoniazid-resistant TB, shorter oral bedaquiline treatment, longer regimens for Mdr/RR Tb patients, and the BPAL regimen for Mdr/RR patients with additional resistance to fluoroquinolones. The isoniazid-resistant TB therapy. Well, for these patients, the recommendation is to use rifampicin, ethambutol, paracetamide, and levofloxacin for 6 months. Adding streptomycin or another injectable drug is not recommended. The regimen would then be 6 months with REZ and levofloxacin. And note that isoniazid is between brackets because actually this drug is, well, it has fixed dose. It's a fixed dose combination therapy, so adding it wouldn't change anything, and it's easier for patients. However, we have to bear in mind that in order to use this drug, the quinolone susceptibility result has to be timely, preferably before starting therapy, because otherwise, if we introduce it after the patient has been on these drugs for a few weeks, on first-line drugs only, we might be generating resistance. The use of the shorter oral or Mdr Tb regimen from 9 to 12 months is recommended for eligible patients with a confirmed Mdr Tb who have not been exposed to second-line drugs for over a month and where fluoroquinolone resistance has been ruled out. This is basically a regimen that is a modification of the regimen that has been approved with kanamycin in 2016, the Bangladesh issue. You're familiar with it. In South Africa, patients would basically use bedaquiline without changing the other drugs. This treatment involves some disadvantages. The fact that etionamide
vamos a ver que no
is one of the drugs has not proved to be very effective. And there might be extended resistant patterns in some countries. This is why the WHO considered at the time the possibility of replacing ethionamide by linezolid, but at the time, the evidence was not enough to recommend this. What the WHO did was to ask countries to carry out research, operational research, with regimens using these new drugs to see the efficacy and safety and be able to issue new recommendations. In the region, there are several countries which have protocols for these new, shorter therapies. I should also point out the interaction of bedaquiline, which is a novel drug for these patients. Because of its liver metabolism, it interacts with all the drugs that inhibit or induce cytochrome P450. So we have to bear this in mind. And in HIV, there are several ARVs that act in this way. An important recommendation is that co-infected patients have to be switched to another ARV if they are on efavirenz. As to the selection of individual drugs for second-line drugs, the basis was the meta-analysis of individual patient data published in 2018. Over 30,104 records from 53 studies in 40 countries were analyzed, and the data published by South Africa were added, data from their bedaquiline regimens, as well as the delamanid evidence that was extended when study 213 was published. In a meta-analysis, failures or relapses were compared to success rates or cases, and a positive ratio was observed favoring linezolid, levofloxacin, carbapenems, moxifloxacin, bedaquiline, and clofazimine. There was a significant association between death rate reduction and the use of linezolid, levofloxacin, moxifloxacin, or bedaquiline. As compared to non-injectable treatment, amikacin was mildly beneficial, but kanamycin and caprimycin were associated to worse results. The remaining drugs were associated with mild or no improvement in the outcome. Based on the results of the meta-analysis, the second-line drugs were grouped in 3 categories that you may be familiar with. The first one is quinolones. Group A, bedaquiline and linezolid. Group B includes clofazimine and cycloserine, and all the others are in Group C. I should point out that imipenem is in Group C not because of its activity, which has been well proved, but because it has to be used at least every 12 hours. And this is why it was included in this group, because of its use-related difficulties. So the recommendation was that 3 drugs from Group A and at least 1 drug from Group B should be added to ensure that treatment will start with at least 4 drugs. This is for longer treatments, and in this way, when discontinuing bedaquiline after 6 months, at least 3 drugs remain during the rest of the treatment. If you cannot use 3 drugs from Group A, then you may have to use 2 from Group B, and then you will have to resort to Group C to complete the 4 drugs based on your needs. This regimen, the recommendation regarding the duration of this regimen is 18 to 20 months. The fourth module or part was about treatment with pretonamide, linezolid, and bedaquiline BPAL, and the recommendation is that this BPAL regimen may be used under operational research conditions in patients with Mdr Tb who are resistant to quinolone and who have not had previous exposure to bedaquiline and linezolid for more than 2 weeks. This is only under operational research conditions. In summary, before starting the shorter treatment and fully oral treatment with bedaquiline, we need to have access to rapid susceptibility testing, especially to identify quinolone resistance. Changes in the shorter oral regimen with bedaquiline using second-line drugs should be assessed under operational research conditions to establish the efficacy, safety, and tolerability, just like the BPAL regimen. All treatments have to meet the standards recommended by the WHO, support centered on patients, informed consent, good clinical practices, active drug surveillance, and regular supervision of treatment. To conclude, all Mdr Tb or RR-Tb patients, including those with proved resistant to fluoroquinolones, may profit from effective all-oral treatments, whether shorter or longer, implemented following a treatment program. Thank you very much.
Hola, soy el doctor Eduardo Gotuso.
Hello, I'm Dr. Eduardo Gotuso. I'm briefly going to talk about the most outstanding facts related to TB because otherwise it would take too long. This is a disease that can be cured. However, 100 million people died of it in the 20th century. Peru was among the 22 countries until 2002, and today it is a country in Latin America which has most cases of multi-drug resistance TB. According to the WHO, well, this is information, the number of people who fell ill every year. 1.8 million, almost 2 million people die a year because of TB. And besides, in this group, there were 400 people who died because they were co-infected with HIV and TB. This co-infection was stressed, and we should remember this. Besides, TB is a disease that can be prevented. We may wear masks, people may be isolated, we have quick and effective treatments, people stop being contagious, and we may provide prophylaxis to risk groups. The first protection is used BCG, and we know that BCG reduces in all studies, given at birth, it reduces pulmonary TB, a very important concept to strength that should be strengthened. There are several studies that show that BCG prevents pulmonary TB. And in the past, we were using a diagnosis method for over 100 years, the Sputum Test, which is still an important test nowadays. There are not too many new agents that have been found in the last 50 years. It's only in the past decade when 2 new drugs were discovered, and nowadays there are 2 more drugs. Besides this, prevention is quite inexpensive. However, TB, MDR, the treatment of MDR TB is very expensive, and the treatment of XDR TB is even more expensive. Patients who are not treated may transmit the disease to 20 to 40 persons a year. A patient who has a second recurrence within the 5 years may be suffering from MDR. In the case of MDR, many patients die, whereas TB kills 2% of the patients. MDR kills over 40%. The treatments that have been used are 5 or 6 drugs for TB, MDR, but for 18 or 24 months, there are many AEs and low tolerance. this situation of having two epidemics simultaneously, this creates a perfect storm. HIV becomes a very important issue. Today, TB is acknowledged to produce nosocomial infection. There is an increase in the number of cases. There is an increase in the case of patients with HIV. And HIV patients only transmit the disease to the healthcare professionals. They just transmit to them, TB, not HIV. And there are outbreaks of Mdr Tb, nosocomial Mdr Tb. We have seen this in several regions since HIV cropped up. It was very important to see how HIV was associated to nosocomial infections of Mdr Tb in Spain, Florida, New York, Argentina, most of, and at those times when we had no treatment, the death rates were very high and death occurred within a very few weeks. One of the important issues is that HIV is the most important factor related to the development of TB. When people get infected with TB, the risk is 5 to 10% of getting sick during their lifetime. But patients who are living with HIV, in their case, the risk is 7 to 10%, so they will all present the disease within 5 years. Secondly, reinfection or being infected with a second or different bacillus is very high in the case of TB patients, and the risk of death is 2 to 4 times higher in patients infected with HIV. We know that TB increases HIV replication significantly, that it also increases the viral load and reduces the CD4 count, that it increases the speed of progression to AIDS and increases mortality. So it's a very important factor. So how could we prevent this? We know that when we get a positive PPD 5 milliliters or more, the advantage is very important. However, when we get a negative results, there is no advantage. So chemoprophylaxis using isoniazid for 6 months in these patients is very important. We have pointed this out 18 months ago together with Dr. Fernandez, that there are many opportunities for prevention, and one of them, which hasn't been used widely in Latin America, is giving isoniazid. Another important point is this one. When we have a patient and we only use sputum tests need 10,000 bacilli per 1 centimeter of sputum. So in the first weeks or months, the patients may be undergoing those sputum tests and the results are negative. So it's very important to use gene expert devices. This is a simple method, a molecular one. It's simple to use. You put in the sample and the reader detects, and after that it detects whether there is resistance, a resistance test. This is done in 2 hours. We participated in writing this first paper, which is one of the important breakthroughs in the area of TB in the last 10 years. We also worked with this in patients living with HIV, and we got positive results. We worked with 131 patients who were enrolled with a high likelihood of finding TB. Sensitivity for TB was 97% and specificity was 98%. So this system is very useful in patients living with HIV. In Latin America, we have been aware for many years of the number of HIV patients co-infected with TB. The figures were very high. They ranged from 2% to 35% in Peru. It's a different thing to say how many patients who have a TB diagnosis are co-infected with HIV. Here, the figure ranges between 2 and 5%, both in Argentina, Brazil, and other countries, as well as in Peru. But if you look at the patients with HIV, we have the figures we see on the screen. And we know that 1/3 of the people living with HIV may be co-infected with TB. We have 1 million of new TB cases worldwide. and they must be assessed continuously. One of the outstanding facts that should be noticed is that the possibility of developing TB is related to the CD4 count when we start the treatment. So the later we start the treatment, the lower the CD4, the higher the risk of developing TB. So much so that this is the first message, take-home message, and this has been acknowledged. We know that when we started using HART, the chance of developing TB drops both in South Africa and in other countries. Developing and developed countries, the figures begin to drop. This is a second take-home message, and this has also been seen in Brazil, where 11,000 HIV patients were treated, and the risk of developing TB when you use isoniazid the right way dropped from 4 to 1.2, but when we use ART and isoniazid, the drop was more important. So we must say that we may prevent TB by using isoniazid. We may make a quick diagnosis using expert. We must start ART as soon as possible with high CD4 counts. We should use antiretroviral treatments to reduce the appearance of TB, and we should remember that Mdr Tb is very frequent in HIV patients. Now we know that the risk factors are a history of a previous anti-TB treatment, direct contact with Mdr Tb patients, or living with HIV or diabetes. So HIV is very important predictive factor of TB in Latin America. When you have patients who have a sensible TB, in nine days, the aerosol level drops significantly. So they're not contagious any longer. But when they don't have a sensitive TB, they keep on being contagious. And it's important to know when we look at the impact of Mdr Tb in HIV patients, the death rate is very high as compared to patients who are infected with HIV but not with TB. And when they have sensitive TB and they are HIV negative, well, this is the curve. Resistant TB with HIV, the death rate is very high, and the rate of contagiousness is also the rate of transmission is very high. So we should take into account this, how contagious these patients are if they have non-sensitive or resistant TB. Several studies carried out by WHO and authors show that the death rate increased where the lower the CD4 count is when they start the treatment. There are also difficulties in managing Mdr Tb, so new drugs are researched. We participated in these analyses when we started studying bedaquiline. We have bedaquiline, which early, after 8 weeks of treatment, the cultures turned negative much faster as compared to the standard regimens. We also found that the QT interval changed, but it was not too important from the clinical point of view. This is an important piece of information, and it was published in the New England Journal of Medicine in 2014. There is a new drug for the first time. Another international group involving some physicians from Peru introduced this new drug. When we have resistant TB, one of the issues is that the death rate caused by TB is very high. So the efficacy, look at the death rate on the screen, it increases whether when there is resistance to quinolones or other agents. But the cure rate drops even more than the one we see in the natural history of the disease. So it drops. It's even worse when we have these resistant strains. So we should remember that Mdr Tb, one of the new problems we face, is present globally at the 4 to 6% rates, but among HIV patients, it's 8 to 12%. So we have treatments for 18 and 24 months, but we have actually using 9-month treatments, oral treatments in Peru. For Mdr Tb, we have used imipenem with amoxicillin, clavulanic, plus linezolid, amoxifloxacin. This is the first information. This was tested on 42 patients. And one of the issues we had is that we had to use a port to give the patients the drugs, but the evolution was good. After 6 months, 75% of patients were cured from the bacteriological point of view. Linezolid, a very interesting agent, was started 600 twice a day, but this brought about neuritis and some injuries, which used to be produced by chloramphenicol in the past. Today, we know that we don't need 600 twice a day, but just 600 once a day. So the AEs become less important. We should remember that we are currently trying to find treatments that target different points so that we may attack TB in several points. So bedaquiline or rifampicin or fluoroquinolones or the laminide, all of them have different sites of action. Recently, well, this study was started in 2015. Last year, the first results were published on 109 patients. This is a treatment for XDR and MDR, but with 3 agents, and it was found that the cure rate was really high. There was good tolerance. However, they used linezolid 600 twice a day. That's why they had neuropathies and bone hypoplasia, even optical neuritis. These AEs disappear when you go down to 600, just 1 tablet a day. This has recently been published, and we know that patients with HIV and TB, both XDR or MDR, may benefit from these new regimes that should be fostered. It's 9 months, 3 agents a day, oral tablets, no injections, and very good tolerance. So I would just end up by saying that it's important to remember that TB is a disease that kills people, but it's a disease that can be prevented with the BCG vaccine at birth by using isoniazid in HIV patients. We should have a PPD 5 millimeters or more is positive, 6 months of treatment, look for HIV co-infected patients, giving them early diagnosis and treatment, because with ARV treatment, the risk of developing TB drops significantly. So these are the key messages for this session. And I haven't mentioned about the clinic because Garcia Marquez has very well described this in this wonderful book, The General in His Labyrinth. So I'm not going to mention this. I will just conclude and thank you for your attention. Thank you very much. It has been a brief presentation, and I would again like to thank you for having invited me to address you, to share with you this quick overview of HIV and TB co-infection. Thank you very much.
Cette table ronde sur le sida et la tuberculose va couvrir tous les aspects, du diagnostic à la prophylaxie, au traitement, y compris au traitement de la tuberculose multirésistante, jusqu'à la problématique des enfants avec la tuberculose. Alors là, nous allons avoir 5 panélistes. On va d'abord commencer avec le docteur Bernard Liotard.
Here there are 6 panelists.
La prophylaxie, puisqu'il y a de nouvelles recommandations. La prophylaxie des patients infectés au VIH.
And we're going to listen to the different recommendations for HIV and TB patients. Dr. Liotard, you have the floor.
Merci, Dr. Pape.
Thank you very much.
En 1993, Jean Pape et collaborateurs
In 1993, Jean Pape et al. showed clear efficacy of TB prophylaxis with INH for HIV patients in Haiti. From that time, several studies with different schemes show the efficacy of this intervention and the need to do away with evolutive TB before starting prophylaxis. In this slide, you can see that only 20% of potential candidates for INH prophylaxis adopted it. Implementation is quite diverse, depending on the countries. Several prophylactic regimens are used, and they all include isoniazid alone or associated with rifampicin or rifapentin. Duration is 3 to 9 months. The ACTG study gave us great hope about the efficacy of this prophylaxis, taking duration to 1 month with the association of INH rifapentin. This treatment regimen also works just like the 9 months of prophylaxis with INH. However, the obstacles to use this shorter treatment are cost, access, and assessment for pregnant women and children. We should also go back to those countries who, just like Haiti, have a high rate of TB. The WHO recommends INH prophylaxis with 36 months of treatment, even sometimes a lifelong therapy. And we have to find a place for an ultra-short prophylaxis with INH and rifapentin. Can this regimen be repeated? At what rate? To conclude, I would say that the multiple treatment regimens for TB include durations that go from 1 to 36 months. Rifapentin is very promising, but the possibility to go to a single drug would be great. Most efficacy studies were carried out before the universal implementation of ARV treatment. At the same time, this has a preventive effect on TB incidence. The reassessment of these protocols is necessary. Thank you very much for your attention. Thank you.
Je peux démarrer? Oui. L'OMS est venue avec un nouveau guide de traitement en 2000.
WHO issued new guidelines for the treatment in 2021 for the treatment of patients who are co-infected, who are infected with HIV or maybe co-infected or not with TB. They were given antiretrovirals when having HIV, and Dr. Patrice Sever will talk about this kind of treatment.
Je vous remercie, Dr. Pat. En effet,
Thank you, Dr. In 2021, the WHO issued new guidelines on when is the best time to start with ARTs in patients who were co-infected with HIV and TB. So, and these are the guidance. In 2013, the WHO will recommend starting antiretrovirals as soon as possible and within 8 weeks after start of TB meds. If the CD4 count of the patient was below 5 per cubic millimeter in 2 weeks, we had to wait for 2 weeks. And why did they issue this guideline? First of all, this approach ensured tolerability of TB meds prior to starting with antiretrovirals. This approach considered the higher risk of developing TB iris in patients with a high CD4 count. It was also seen that it didn't have an impact on mortality in 2017. What happened in 2017 with these recommendations and guidelines for symptomatic patients with TB? For these patients who have symptoms, WHO suggests delaying the treatment with antiretrovirals and working on TB in the meantime. In 2021, this recommendation was, or these guidelines were reviewed. WHO recommends starting antiretrovirals as soon as possible. That is within 2 weeks of initiating TB meds, regardless of the CD4 count. To decide this, they took the following into account. After a systematic review, they found that there was no impact on mortality, whether you started after 2 weeks or within 2 weeks or within 8 weeks. An early start of antiretroviral treatment might increase the risk of TB iris without having an impact on mortality. As a matter of fact, the committee insisted on the benefit of the overarching treatment of the patient, starting antiretrovirals earlier. They also stated that this regime would be better tolerated than older regimens. So, in the past, they would delay the treatment. There's less need, to delay till after initiation of TB meds. So WHO suggests starting antiretrovirals while waiting for the results of TB tests. If the diagnosis is confirmed, treatment could be started. They are pros for this approach because it simplifies the programs and makes it possible to better treat the patients who have been started on antiretrovirals, and this approach may reduce the risk of losing the patients because using more powerful antiretroviral treatments reduces the risk of TB in the case of patients who have a non-diagnosed TB and who suffer or who are ill with HIV. So we need more research on the optimal screening strategies for TB and on the treatment with antiretrovirals in patients with symptomatic TB. We also need further data to guide the implementation and the feasibility of using these treatments in low and middle income countries. And it's urgent to have integrated sites that treat TB and HIV jointly. Thank you very much. And now we will talk about Mdr Tb. There is a new molecule available for the treatment of Mdr Tb where we could use shorter regimens and on an outpatient basis. Now I will give the floor to Dr. Viltran, who will talk about his experience in Haiti of treating patients with Mdr Tb patients and patients who are co-infected with HIV. Thank you for the introduction. Before the new regimens were introduced, at GESCIO, we used until 2019 a regimen which was a treatment for 24 months with 2 stages, 24 months with kanamycin, capromycin, levofloxacin, ethionamide, cycloserine, and pyrazinamide. And after that, 14 to 16 months with a different drug. And starting in 2018, between 2018 and 2019, we used 425 patients, some of them with HIV, and we found that many patients had severe nephrotoxicity with a success rate of 80%, a death rate of 11%. The treatment of Mdr Tb in patients co-infected with HIV, well, we use drugs with many AEs, and there are not too many differences regarding the results for patients who are co-infected and patients who are not co-infected with HIV. The results of the treatment are very positive for patients who are co-infected, and there is a low, however, there is a low success rate in the patients who are HIV negative. However, with a new regimen, the guidelines of the WHO, and oral treatment, we achieved good results for patients who are HIV negative, as well for those who are HIV positive. And this regimen is bedaquiline, levofloxacin, linezolid, clofazimine, pyrazinamide, and this regimen is given for 20 months. We have also analyzed a sample of patients. Starting in 2019, 4 of the patients were co-infected with HIV. There were AEs. None of them very serious issues, but many of them had some liver toxicity. With this regimen, the success rate was 97%, and the dropout rate was 3%, but no deaths. We had a success rate of 100% in patients co-infected with HIV. We believe that with this new regimen, we will get good results with patients living with HIV. Thank you very much for your attention. For some years now, we have improved our diagnosis methods. The following speaker will talk about this applied to HIV and TB patients. I'll give the floor to Dr. Jan Just. Thank you, Dr. Pat. With the clinical presentation of a disease, the two conditions are very similar. There is fever, weight loss, lymphadenopathy, sweating, extreme sweating. But with the tools we have and the recommendations of the WHO, well, we have several tools, as I already said. We have bacilloscopy, which is used less and less because now we have Gene Expert, which is more specific and gives us results much faster. We also have Gene Expert Ultra, which is more sensitive, and X-rays and cultures, which are very useful. With all these tools, it's easier to make a TB diagnosis. And based on our experience at Gestio and the retrospective studies, and through the screening for HIV, and based on studies carried out in 2018, we carried out the retrospective study considering 1 year, and we realized that there are 30,000 patients So we had 30,000 patients. Out of those screened for HIV, 10% had chronic cough, and out of these 10%, 22% were diagnosed with pulmonary TB. That's why it's so important to use a comprehensive approach to include the TB screening in the HIV departments or care centers. On this slide, we can see the importance of gene expert for the diagnosis of TB. This is based on a prospective study where we looked for active cases in the community, in the shanty towns, in Port-au-Prince. We screened 100,000 people, 7% had chronic cough, had chronic cough for over 2 weeks, and out of these patients, we found 1,110 cases of active TB. Out of these, 977 were HIV negative, and the remaining were HIV positive. Among the HIV negative ones, 212 cases wouldn't have been diagnosed without gene expert, and among the HIV positive patients, many wouldn't have been identified as TB patients without gene expert. So we realize how important it is to use gene expert, clinical examinations, cultures, and X-rays for the TB screening. But we should remember that in the case of children, the diagnosis of TB is harder to make. And I will give the floor to my colleague who will talk about this, TB in children, TB diagnosis in children. Dr. Alsenat will talk about children and on how to improve the diagnosis, how to make an early diagnosis of TB in children. Thank you very much, Dr. Papp. Pediatric TB is a public health issue, a very important one, especially in some countries. Many cases have been diagnosed in children under 2 years. And MDR, pediatric TB, has been diagnosed. It's a post-bacillary disease. And there are non-specific clinical signs and symptoms in very young children. Besides, there is a rapid progression from infection to active disease. There is a high mortality rate, especially in children co-infected with HIV, who suffer from severe malnutrition and who present severe forms of TB, such as Mbrtb TB or meningeal TB. Unlike adults, in the case of children, the microbiology is not enough to confirm the diagnosis. In a trial carried out, a study carried out between 2011 and 2015, with 679 children who underwent gastric intubation, it was seen that only 1.77% of these children had a positive bacilloscopy, and few of them had positive sputum tests. With gene expert, the detection rates were higher. This shows that the results were wide-ranging. In most cases, the diagnosis of TB in children, to make a diagnosis of TB in children, we need a clinical examination and X-rays. However, the sputum tests are still important to confirm TB. we face challenges related to diagnosis, but also other challenges from the point of view of treatment. We have to say that the dosage, the pediatric dose has been extrapolated from adult dosages. We need pharmacokinetic studies to define the right dose for children. In the case of complex TBs, that is the bone TB, meningeal one, or miliary one, we don't know whether the dose used for children is the right one. At the Gesky Center, we are carrying out a study to find out how we could find how to define the right dosage of for children with malnutrition and to analyze the metabolism of rifampicin and isoniazid. We are analyzing the impact of the prophylaxis and we try to find the right dose for the treatment of children suffering from Mdr Tb and for prophylaxis. To wrap up, pediatric TB is underdiagnosed and has high mortality in very young children. We need to develop better diagnostic tools for children and we need to do more research to find new opportunities for TB pediatric treatment. Thank you very much. This has been very interesting. Now, Dr. Marie Deschamps will share some closing remarks after this roundtable on TB. Thank you very much, Dr. Papp. First of all, we'd like to congratulate the speakers and thank them for going over the most important facts on co-infection of TB and HIV. Dr. Otto talked about the duration of prophylaxis in patients co-infected with HIV and the different regimens. And he stated that we must keep on doing research. Dr. Sever analyzed the consequences of major changes in the WHO guidelines, treatment guidelines for patients co-infected with HIV and TB, and he also called for research to be continued in this area. Dr. Lebrun talked about the new approaches and the regimens to treat Mdr Tb and on the way to treat co-infected patients, co-infected with HIV and TB. He also talked about mortality rates. Dr. Just mentioned how from the clinical point of view, these two conditions are similar, HIV and TB, and how the progress and early diagnosis made it easier to treat these patients. He pointed out the role of the bacilloscopy cultures gene expert and gene expert ultra. Dr. Zena talked about pediatric TB and she stated that pediatrics is always the Cinderella where she talked about the diagnosis and treatment of diagnosis in children, and she mentioned the need to keep on researching to reduce death rates among children and optimize their treatment. Thank you very much once again. I would like to thank the panelists who have shared excellent presentations. Thank you, Dr. Papp. I would like to thank the panelists for their contribution, for their presentations in the second session. I would like to thank Dr. Lyoto, who has talked about the guidelines. He also talked about the Haiti meeting in 2018. The next speaker talked about the main guidelines, recommendations from that symposium. I would like to thank Dr. Maria Rodriguez, who stressed, talked about the new guidelines for the treatment of TB and Mdr Tb on behalf of the Dominican Republic and WHO, Dr. Gattuso, who shared his experience in Latin America and specifically in the case of Peru. And he also talked about the co-infection between the co-infection of HIV and TB. I would also like to thank all the participants for having attended this session, and I hope this has been useful and interesting. We hope that all the lessons learned in these sessions will help us in our daily practice, in our professional work, so that we are better able to understand all the issues related to HIV and TB co-infection in Latin America and the Caribbean, with a special focus on AE's new regiments and the WHO guidelines. And we would like you to share what you have learned in these sessions with your colleagues and peers who have been able to participate in these live sessions. These presentations will be available in the IAS website, and you will be able to access all these presentations for free on that site. You may visit the site using, you may visit our site, the IAS site. The third session will start at 2 p.m. Thank you very much. Stay logged in for the next session, just as you stayed logged in for session 2. Thank you very much. See you later.
Okay, thank you very much.